Thank you very much. Thank you for having me. I can only think that I'm here for a couple of reasons. The one is that they're going to need a non-expert in the room. Hello, guys. I'm your man. And I'm very opinionated. And so I'm going to give you the ICU perspective a little bit. And as we go, I'd like you to, if at all possible, almost frame this in the surrogate decision makers' thinking, because that's a lot of what we have to deal with. The great difficulty that is superimposed upon the surgical decision to operate or not is that it is a binary, time-stamped, intervene or not intervene decision that will materially change the trajectory of that patient's care. We're either going to be going to try, I hope, in a more multidisciplinary and collaborative manner, to get this person back to a place where they would want to be, or we're going to have to focus on how we're going to make them more comfortable and allow them a more dignified, pain-free death. It is that simple. This is really hard. This is some of the hardest stuff we do, and this scares this scares me a lot. Because you have amazing success stories of people, and we've heard of one of them. Mark Hurwitz has no cognitive dysfunction, but for the fact that he supports the Brumbies. Sorry, Mark. It makes two of us in the room. and so in all of this, we all have those unexpected survivors who come back and say hello to us and bring their families with them. And we have those people who we change care pathways for and allow to die in our care. And then late at night, in the bitter watches when the demons come, you think about them and wonder if you ever made the correct decision. So this is incredibly, incredibly hard. And I think that as a society, we contribute to this. Death has replaced sex as the Western civilization's greatest taboo. We are more likely to speak to children about sex than we are about death. And that's fundamentally wrong, because not every child will end up having sex. And the biggest problem that we've got here, all right, to continue with this theme, is that we've got to have a look at this, all of this grey that sits in front of us, and then, in a very binary fashion, say, it's not grey, it's either black or it's white, because I'm going to make binary decisions based on whether I decide this is black or white. So this is incredibly hard. And I'm going to hopefully try and tell you what I think about it, provided we have one agreement. I'll tell you what I think, and if you think that's nonsense, you don't listen to what I have to say. If we can come to that agreement, I'll proceed. Discussions about futility are also a little bit uncomfortable, and so perhaps we should be thinking more about low-value intervention. It's all about probabilistic thinking, which I'll get to in a little while. I find it fascinating. I also had to look it up. And in all of that, we need to think about how we have this shared model of decision-making, how we come to the best possible decision all together. And I think fundamental to that is how we take consent and whether we can do it better than we currently do already. And the involvement of surrogate decision-makers. And I have some very strong opinions, and I'm fascinated to hear from ethicists and true experts in the field about this, how one frames that for surrogate decision-makers. And then at the end, in great arrogance, I will maybe make a few suggestions about how this might be conducted using what I tend to think works for me. Futility is a crazy concept. It used to be zero chance of success. This practice is totally unethical. If you did CPR on somebody who suffered decapitation, you're mutilating a corpse. There's no justifiable way that you can continue to practice like that. In the last century, when I went to medical school and started training, we attempted to use statistics and said that if you did something 100 times unsuccessfully, the 101st attempt would be deemed futile, which is important because it gave us kind of a 1% threshold, but more importantly, it contextualized it. It said, what does this look like in my environment? Siva touched on this. What does my support structure look like? And now there's the attempt to use clinical judgment. So any therapy you might withhold, irrespective of a patient's wishes, is probably futile. But much, much, much more important, perhaps, is not dealing with that so much as a concept as thinking about, are we more likely to be providing what is going to be a low-value intervention? Now that's really, really hard. But we all think this way, even if we don't realize we're doing it. We all engage in probabilistic thinking, every clinician in the room. What we do is we almost, in a sort of logistical way, list all of the factors influencing our decisions. We assign them importance, we determine their contributions, and then ultimately we arrive at this decision. It's very hard to do, and there might be a way to do that in a more cognitive way. And so if you'll forgive me, I'll tell you the way I kind of think about it right at the end. And if that makes sense to you, hopefully we can agree on something. The usual framework, there's often a medical consensus within disciplines, between disciplines, the second opinions one seeks quite frequently, discussion with the patient or surrogate about what they would find acceptable. I think this is the best way that we can treat you. Is that acceptable to you? Does that line up with your thinking? And then you make a plan, you evaluate, and you continue reevaluate. And here's where the difficulty starts to come in. If you look at intensive care practice variability, it's massive. If you want 3 opinions, just go find 2 intensivists. There's less variation with simple interventions. Most of us will use the same thromboprophylactic. But when you get to more complex interventions, it's massive. And there are polar opposite opinions in 10% of anesthetists when it comes to end-of-life decisions. That's fascinating. 1 in 10 of us have polar opposite decision-making processes to the other. That in and of itself means that it's very, very difficult. And why is that? Well, it's easy to justify intervention. You can always say, I'm doing my best. I'm trying everything I can. It's an easy position to defend if you're not thinking deeply enough. What is a meaningful outcome? I don't know. I know what I would want for myself is different from what somebody else might want for themselves. And I cannot help but impose my own worldview on some of my thinking about my patients. I can't get away from it. Time brings clarity. So if you can just buy another day, hey, let's just see what happens in it. The more time you take, the more clarity will, and sometimes that's totally appropriate. But sometimes you don't have that luxury. And we are not good at this. I was never trained for this. It's time-consuming. It's difficult. It's emotionally draining. So we are not fundamentally good at this, unfortunately. I speak here for myself. And so what about consent? I have a great difficulty with this. This is a study on palliative chemotherapy offered to patients with non-survivable lung cancer and colorectal cancer. The number of patients who thought they might be cured of their chemotherapy, which was clearly palliative in nature, was about 70% for the lung cancer patients and 80% for the colorectal cancer patients. 80% of the patients in the study actually elected to undergo this kind of palliative chemotherapy, and in follow-up, the oncologists who offered this palliative chemotherapy, only 20% of them would have elected it for themselves. It brings in fundamental questions about consent. And what was perhaps even more worrying is that patients and surrogates who rated their clinicians as better communicators were more likely to be mistaken about the intention of the chemotherapy itself. This terrifies me that consent was not adequately taken. And it appears to be not just about whether cure was plausible or not, but extension of life and of symptom relief in addition. And I wonder if I had to say to some of my intensive care patients, I can probably get you home. 1 chance in 5 that you'll be able to self-care. And for the next 6 months, you're going to make a massive investment in hard work and pain and suffering. Is that okay? I wonder how different people would answer, because this appears to be very, very important to people. In people, this is from the Kaiser group, so please accept the American spin on it. In people who have been faced with serious illness, a large majority have thought about what their wishes would be in the context of a life-threatening serious illness. About half in this group, multinational group, have at least had some conversation, but very few have documented this. And what's interesting is what these people find important is fascinating as well. Way up here, and again, perhaps the American spin on it through an American HMO, is that their family not be burdened either financially or with serious decision-making. I think a cautionary tale for those of us who engage with surrogate decision-makers. Very important that these people do not suffer, that they have loved ones around them, and perhaps that their dignity is respected, and to a much lesser extent, that they live as long as possible. So this is fundamentally important to people, and their wishes, I think, are becoming much more explicit, if they are not explicit already. And all of this, in my grave concern that I don't take consent from patients to admit them to intensive care in any formal way. And I don't do it on an ongoing basis unless I'm about to embark on a conversation about whether or not we should change a direction of care for any given patient. The other thing which helps us, or at least cautions us in this, is that there's an increasing body of ICU literature that our longer range and medium range outcomes are not fantastic. Depending on the case series you read, up to 40% of our patients who are discharged from the ICU after 3 organ systems going down will die within 90 days. That's massive. That's a lot worse than I thought. And I feel quite pleased with myself when I discharge somebody alive. They go out the door and they're not still on the ventilator. In people who leave the hospital functionally disabled, they have a 7-fold higher risk of dying in that first 90 days than people who do not leave the hospital functionally disabled. And there are a lot of other factors that contribute to that, advanced age, comorbidities, and malignant disease being particularly strong ones. And a key question, how much of this is modifiable? Well, I don't know, because attempts at modifying these risk factors haven't really helped a great deal, including intensive physiotherapy, rehabilitation, and so on and so forth. And to show you one worrying surgical study, this is actually a study targeted at early goal-directed mobilization, targeting a modifiable risk factor as discussed in the previous slide. Small study in surgical patients who were ventilated for more than 3 days. 1 in 2 of those patients were able to go home straight from hospital discharge. So only half of those patients were going home, and of those who went home, 1 in 3 walked there. As in walked out of the hospital front doors and climbed into a taxi. It's a small study, but it's of surgical patients who clearly had a significant imposition of in their perioperative course requiring intensive organ system support. And this worries me. This worries me a great deal. So where are we right now? Well, it's lots of good news, as I'm sure you can tell, but here we go. It's difficult due to uncertainty. We're all owning that. It's important because of considerations around patient autonomy and shared decision making. I worry our consent, particularly from an intensive care perspective, is incomplete. And our outcomes are not as good as we think. Unfortunately, intensive care isn't nearly almost as good as it thinks it is at getting these people back to a place where they may or may not find acceptable. And in this context, I want to introduce a little thing I've been thinking about quite a bit, particularly based on some of the reading I've been doing. And again, the experts may address this, and I'm actually fascinated to speak with them a little bit later about this. Because the way we frame our questions and the way we frame these decisions is very, very important. We obviously engage in a shared decision-making model. We put the patient at the center of the conversation we're having, and we ensure that we try our best to do the right thing by them. And we absolutely accept that the patient's choices are paramount. But the problem is, the way we present that choice is fundamentally important to the decisions those patients make. And their appropriate use is actually valuable in bypassing cognitive limitations, right? Such as putting something at the top of a list. If you put something at the top of a list, a human being is more likely to select that. And you can test this by rearranging that list in population studies. And therefore, the manner of this presentation has a disproportionate effect. Top of the list we've discussed. If you couch a conversation about survival instead of it being about mortality, you're far more likely to have a patient select the intervention. And the same is true for default options for end of life. And there's good studies to show this. What we don't really know is what to do about them. So if you consider a simple question with a complex answer, in the event that your heart stopped, would you like us to try to restart it? There are a number of ways that you can do that. This is a difficult conversation to have at the best of times, because there's actually pretty good data it erodes trust. I don't like talking about this if I can get away without it, because I believe it breaks down trust and it actually almost undermines the communication of care, which I would be far more happy to communicate to a patient or family. If your heart stopped, you'd want us to do everything to treat you, wouldn't you? It's very different to, if your heart stopped, would you like us to try to restart it for you? Is very, very different to, in most cases like this, we would not usually try to restart your heart. Does this seem reasonable? So the clinical nudge is incredibly important. And even using it, by using them, not only will you change the way our patients select their care options, but your capacity to communicate care to them is greater. And here's the thing, we can't help it. We're always going to nudge because we're human beings. So let's do it properly and let's do it thoughtfully. All right, here's the arrogant personal perspective on things. Because I find this hard for myself, I try to turn this into the most cognitive process that I possibly can. Right? People have heard me say this before. I have one synapse. It's usually inhibitory. And so when I'm just considering things like this, it's totally overloaded. And the first thing I think about is the physiological prognosis. And yes, Siva, I go to those calculators. If I've got a patient with a head injury, I go to the Project Impact database and I run those numbers so that I can talk to families and say to them, put statistics in a manageable way. 4 out of 5 people with this condition will have this outcome. You know? Use careful words like educated guess. But yes, I try to get as best an idea of the physiological prognosis as I can to tell me what that person's going to be doing with their heart, lungs, and kidneys in a couple of days. Try and get an idea of their prior wishes. Have they articulated this in any way or form? And these are direct questions that are actually quite easy to ask. And then previous function, much more difficult. Much more difficult without actually talking to the patient. And this is where it becomes easier when you have a patient in front of you, because you can ask them those very direct questions. When it's with surrogate decision makers, it becomes much more difficult. And I might suggest, in a very arrogant way, that this might be a couple of things to think about. I'm sorry, I realize how arrogant it is to put such a slide up and say compassion and take time. I know to whom I'm speaking, but it's worth saying again. It's worth re-emphasizing, because sometimes you get caught when you're rushed and you're busy and it's 2 a.m. and you've just got 2 other patients' blood on your hands. Not literally, of course. The ethical standpoint, which is to say to a surrogate or a group of surrogate decision makers, we will never ask you to make the most important decisions about your family member's life. I'm not going to sit here and ask you to tell me what to do. It gives me horrors when I read things in the lay press that say, they asked us to switch our family's members' ventilator or life support machines off. That is horrendous. We make medical decisions and calibrate those decisions about whether they are reasonable or not against the understanding of the surrogate decision makers. Tell me about your dad, your mum, your sister, your brother. Helps. It helps a great deal, because it not only gives you information, but it shows that you care. It really shows you care. And then I often frame it this way. If I was talking to them right now, this is what I'd say. And sometimes that's along the lines of saying to them things like, I'm sorry. I can't get you back to where it's likely you would want me to get you back to. And families, I think, respond to that reasonably well. Forgive me the arrogance of the last slide, and thank you so much for your attention.